is the carboplatin's paclitaxel every 3 weeks.
Okay. Okay, thank you. Professor Raj.
But I think the European trial have a different dose, or especially for the carboplatin. If I'm
European trials, they can 3-arm trial, 3 weekly, carboplatins paclitaxel every 3 weeks. The other arm, like the Japanese trials, the paclitaxel 80 milligram per meter square with carboplatin every 3 weeks. And the other arm gives the carboplatin and the paclitaxel every week. The carboplatin AUC2.
Thank
the
you.
paclitaxel 80 milligram per meter square. So including the arm of the Japanese trial and the standard of care. The 3 arms, no difference as regards the progression-free survival and the overall survival. Look to the toxicity profile. The standard arms, the toxicity profile is about 42% in the weekly dose of paclitaxel was 63%. High
Thank you.
profile in the weekly dose.
Thank you. Thank you, Professor Mohammed. Professor Raj and then Professor Ahmed Selim.
I mean, the ICON 8 data has now been presented, which was a repeat of the JGOG trial. And the ICON 8 studies showed a negative result.
Negative
so there
results.
was no survival benefit
Of the dose-dense regime.
Weekly carbotaxel.
Thank you. Professor Ahmed Selim.
Just to clarify the question to the audience, because yes, the standard of care of after surgery is the adjuvant carboplatin taxol treatment, but the question is the dose dense for the participants who are not acquainted what is the meaning of the dose dense. The dose dense is the weekly treatment examined before of the taxol treatment. Yes, the adjuvant is the taxol carbo, but the dose dense, the controversy or the we are speaking about the dose dense. No standard of care dose dense accepted today. So for the participants, yes, the carbotaxol is the standard of care, but in the 3 weekly regimen and not the dose dense as a carbo.
So the standard of care is still the three weekly regime of the carboplatin and taxol. Next statement, please. Adjuvant treatment approach to epithelial ovarian cancer should keep in mind the intrinsic, histological, and biological differences, such as that in type 1 and type 2 subgroups, the low grade and high grade, those with the P53 mutations and those without. Please vote. So how can we keep in mind the intrinsic, histologic, and biologic differences when we are giving the adjuvant treatment? Okay, Professor Muhammad Hassan.
Still, the adjuvant treatment, as we told, the carboplatin taxol for all the histological type. But if we look to the prognostic factor, if there is difference according to the histology, yes, in stage 3 mucinous or endometrioid types, the prognosis is better than the stage 3 high-grade carcinoma. But up till now, we have no validated marker as regard the,
so does this
the chemotherapy according to
would that
all
yes
stage 3 and 4 treated by the same
Okay. Professor Gamal Husseini and then Professor Basarif.
I'm talking about the role of adjuvant, whether to give adjuvant chemotherapy after surgery or not. This is important to differentiate between grade 1 and high grade tumors. Also, the differentiate between epithelial, the routine 1, serous or mucinous, and the clear cell carcinoma. So clear cell carcinoma, regardless of the grade, you will give chemotherapy in early stage, but epithelial tumors with grade 1 after surgery can escape the chemotherapy.
But that wouldn't affect your decision of which drug to choose?
There is no difference in the drugs.
No difference,
No.
okay.
Except in the mucinous type, in the metastatic part, sometimes you can give the chemotherapy of the colonic types. You can give
Okay.
Fox or Fulfil.
Okay.
There's some data about the mucinous type.
Okay. Professor Basarif?
So I don't think it will differ in the decision setting for giving the adjuvant treatment in type 1, type 2. In type 1 and type 2 it is the same, but I keep in mind because I know that the response is different from low grade to high grade. The low grade, I still have some sort of chemoresistance more than is chemosensitivity for type 1. But I do believe that it differs for BRCA mutation, for giving the other lines like bevacizumab and PARP inhibitors, which I think show more and more response with the wild types for the BRCA positive tumors, which are not present here in Egypt, by the way, but you have to put in mind for the second and third lines of adjuvant treatment.
Okay. Thank you. The next statement. Adding anti-angiogenic, anti-vascular growth factor antibody to combined platinum-based first-line adjuvant chemotherapy should be considered in all advanced stage ovarian cancer patients, irrespective of the presence or absence of residual disease. Please vote. So this is using the bevacizumab routinely in advanced stage disease following cytoreductive surgery. I will take a couple of comments on that question, please. Any comments? Yes?
Regarding ESMO guidelines, which has been reported in the ESGO book, that it is bevacizumab or Avastin is advised only in recurrent ovarian cancer, not as primary treatment.
As regard the role of adjuvant bevacizumab in the frontline and the maintenance treatment, we have two trials address this: the 218, the GOG 218, and the ICON 7 trials. The 218 they give significant population-free survival, but it's moderate, about 3.8 months. The ICON 7 gave non-statistical improvement in the population-free survival, only mild improvement, 2.4 months. So we up to now the FDA approved and didn't approve the BEVA in the front line. But if we look who is the patient which benefit from the bevacizumab, according to the GOG 218 patient which has ascites, the median progression-free survival and the overall survival is has
improved.
a benefit with them. According to the ICON 7 trials, a patient which has stage 4 disease and stage 3 treated suboptimal high residual disease
Yes.
has a benefit from adding bevacizumab. But up till now, we has no FDA approval for the BEVA. Waiting, I think we are waiting the FDA by June 2018.
Thank you. So the acceptable scenario where bevacizumab could be introduced in the primary adjuvant chemotherapy is when a lady's got unacceptable residual disease following surgery. Thank you. So statement number 9. In advanced ovarian cancer, if complete or optimal cytoreduction thought achievable only via ultra-radical surgery, multi-visceral resection, it is still preferable to neoadjuvant chemotherapy. Okay. Professor Ahmed Mustafa.
I think the concept of cytoreductive surgery has been changed with the introduction of the peritonectomy concept.
Peritonectomy.
Yes.
Okay.
And how we can do stripping of the pragmatic peritoneum, pelvic peritoneum, parietal peritoneum, and so we can save unnecessary resected viscera. So this is the change. And this depends about the experience of the surgeon, the experience of the surgeon in dealing with tumor in the upper abdomen, And this is the change, I think, that have been evoluted in the last years.
So if we could do ultra-radical surgery, it's still preferable to do all that and rather than giving new adjuvant. To Professor Wahid Yusri? Okay.
I strongly disagree for this statement. Number one, if you, as you said before, if you open new planes of tissue, you will add for more implantation of tumor tissue, may be more resistant because the blood supply will be less. You cannot do ultra-radical surgery without intraperitoneal chemotherapy immediately.
That's interesting.
Yes,
okay.
This is the only situation that you can go for ultra-radical surgery to achieve R0.
If you are giving...
Go immediately for intraperitoneal hyperthermic chemotherapy, the patient will have many implantations in new areas which may be difficult to be treated even by resurgery alone. So I strongly disagree for that.
Thank you, Raj, and then you.
This type of surgery will have many morbidities and maybe mortalities, and it will delay the onset
chemotherapy
of adjuvant chemotherapy after that.
Thank you, Professor Raj.
Okay, I think one needs to remember that neoadjuvant chemotherapy does not eliminate the need for ultra-radical surgery. We've been practicing ultra-radical for many years now, and for select cases we do offer neoadjuvant chemotherapy. 40% of those cases still need ultra-radical surgery to achieve a good surgical outcome.
Yes.
With primary surgery, our rate is about 60%. So neoadjuvant chemotherapy may reduce the percentage to some degree, but does not eliminate it. And my biggest worry about neoadjuvant chemotherapy is that when people offer it because there's upper abdominal disease and then do a CT scan after 3 cycles and still see disease in the upper abdomen, they end up not operating at all.
Mm-hmm. Okay, thank you. Professor Ahmed Morsi?
I think usually we have to know beforehand, is this cases can be resected or not by MRI and by CT. So if before surgery you think that the disease burden is very high and you cannot take it out by surgery, start by neoadjuvant chemotherapy. But we are speaking now about a scenario in which that you have explored already a case and you find it that it needs a multivisceral resection to achieve a complete cytoreduction. I think you should go for that if you are capable to do that. If you are capable to do a multi-resection in a case that did not receive preoperative chemotherapy, I think it's better to do it immediately if you have the capability to do that.
Thank you. Professor Saeed Abdelhadi and then Professor Gamal Amir.
Yeah, I think in very few centers, I'm aware of 2 or 3 in Europe who can do this upfront ultra-radical surgery with proper cytoreduction. If you can do it, if you have the surgeons, the team, and the visibility expertise, and usually they are surgical oncologists who have reverted to gynecology. It's okay. I'm aware of 3 or 4 in Europe. Otherwise, it would be the neoadjuvant, the best solution. Yeah.
Professor Gamal Amir?
I think we should differentiate between visceral resection like part of small intestine or right side of the colon,
spleen,
the second part of the duodenum and head of pancreas and the rectum and the bladder. I think if you can achieve removal of loop of intestine or right hemicolectomy or transverse colectomy, it's okay, but don't rush to go to do Whipple in addition or total pelvic exentration. So you remove what is easy and what you are capable of without major morbidity or complications, and then you give chemotherapy and then you do research.
Thank you. We'll move to the next statement. Systemic complete pelvic and para-aortic lymph node dissection should be part of the surgical staging of advanced and recurrent ovarian cancer, even in the absence of radiological lymph node abnormality. Please vote. Okay, yes, Professor Said.
I strongly disagree with that one. There is no systematic complete pelvic and para-aortic lymphadenectomy even improve the survival. There is evidence that it does add morbidity, especially if there is no evidence of positive lymph node.
Thank
Still,
you.
the class, I know the surgeon are going to say the opposite, but that's not the standard of care. Still, your aim is to remove all
Bulky
macroscopic
disease.
visible disease
Yes.
and palpate for the lymph nodes. If you can do sampling, that would be okay, but complete systematic, I don't think anybody
In advanced disease. Okay, thank you. Professor Bassarefi?
So I'm here speaking on the side of oncosurgeons, and I do agree with Dr. Said. It's evidence-based now, according to the Lion trials that we have, after publishing the Lion trial results, that we have no role for systematic lymphadenectomy in stage 3 and 4 ovarian cancer, just removing them as a part of complete site reduction, optimal site reduction. But the thing that I'm aware of is that I have to say, in the absence of radiological lymph node, because some surgeons or some gynecologists have taken the Lion trial results and then are going to omit all the lymphadenectomies. For the systematic, yes, no systematic lymphadenectomy. But for sampling, at least I should expose the retroperitoneum, just not to put my finger on the aorta and IVC above the peritoneum and said, there is no lymph nodes. And so iliac vessel said no lymph nodes. I have to expose the retroperitoneum and I have to palpate thoroughly and remove any grossly enlarged significant lymph node. Otherwise, no role for systematic lymphadenectomy advanced ovarian cancer.
But if you radiologically assess the patient preoperatively and you're confident there is no abnormal lymph nodes there, you do not need really to open the body. If you are not intending to operate in this area, just leave it well alone. You do not need, you feel it, but you do not need to explore it and open the retroperitoneum to feel it. Professor Mohammed? In the advanced disease, okay. Professor Rajnaik.
I mean, there is now a randomized controlled trial just presented at ASCO this year, the Lions trial from Germany.
Yes.
And again, it was a negative result.
Negative.
So for those where complete site reduction was achieved, they were randomized intraoperatively to systematic lymphadenectomy or not. There was no survival benefit. And this replicates the original RCT done by Benedetti Panici many years ago.
Yes.
So we now have 2 randomized controls trials saying no benefit
No.
and significant morbidity associated with it.
Thank you. Next statement, and we'll have maybe 5 or 10 minutes, we'll conclude the session. Chemotherapy is the preferred primary treatment modality in recurrent ovarian cancer. So in recurrence, the default approach is to just really give further chemotherapy. Please vote. He's keeping quiet, yeah? Okay. So the majority either neutral or strongly agree and agree. Professor Magid Abu Sada?
Yes, I think if the recurrence can be removed surgically, I think you have to do surgery at first before giving chemotherapy.
So to quantify the statement, Prof, you mean if the recurrence is isolated in a resectable area, it's better to really go...
it is easy to be removed. Surgery will be preferable to be followed by chemotherapy.
Professor Gamal Husseini, okay? Press on the button as well. Press on the button to... Professor Gamal...
It depends on what type of recurrence this is. Platinum resistant to platinum sensitive. So platinum sensitive, you can try surgery, and in platinum resistance, the role of surgery is debatable, except if, for example, if you can do HIPEC, maybe will be beneficial regarding of the extent of surgery as morbidity. But chemotherapy should be given or not be given. Nobody knows in the resistant type after HIPEC is beneficial or not. We don't know.
Thank you. Professor Muhammad Al.
I totally agree with upfront chemotherapy.
Thank you. Professor Sean Kehoe.
I think you have to divide your patients here. We've got patients who are not resistant to chemotherapy. I think you've got options. I went kind of in between in saying that at this moment there may be some patients who are going to be suitable for surgery and chemotherapy. Some patients, maybe the chemotherapy is preferable first. So in this situation, I think I'm in a neutral position saying it depends really on the individual patient. I think if it's resistant disease, then your surgery is really on the palliation side of things, and you're really on chemotherapy land. So depending when the recurrence occurs will dictate whether either route is okay. When the desktop 3 gives the overall survival results, then for that cohort of patients, in other words, those who are non-resistant patients to platinum, primary platinum, we'll find out then really what's the best thing to do for them. So it's probably you have to give options to patients here, because we don't know the answer. There is no clear answer at the moment.
Okay. If I may ask a question as a branching from this one, where if we find a radiological recurrence in asymptomatic patient, she's not really complaining or so, just incidental 3 by 4 centimeter pelvic recurrence in asymptomatic patient, what would we do?
Gordon Ruston has done this trial, and what he did was randomize patients to a rising CA125, give treatment, even though they're asymptomatic and you can't find anything, versus symptomatic or radiological evidence of disease. What they found was that on a rising CA125, you reduce the patient's quality of life, but not overall survival. So if you do find disease present at recurrence, even though they're asymptomatic, it's reasonable to treat at that stage.
Thank you. Professor Wahid Yosri?
What do you mean by asymptomatic recurrence? That not metabolically active, or
no, the patient is not. The patient is not suffering.
Markers? Because sometimes we discover lesions by CT only,
yes,
which are not metabolically active by PET-CT, and you don't have an elevated markers.
Okay.
Can we put the patient under follow-up, or we'll go for surgical removal and pathological assessment in this case to avoid progressive recurrence? This is the question. In my opinion, I will go for surgical removal and pathological assessment to see that this patient is actually in a rare remission or just a metabolically inactive tumor, residual tumor.
That's right. Thank you, Professor Noor, and then Professor Saeed.
I strongly agree with what you said. We have to remember that recurrent ovarian cancer in most of cases is an uncurable disease. You could achieve a disease-free survival with the utilization of many tools, some of which may be surgery or chemotherapy or others. But you have to remember that whatever the tool that you are going to use, it has to be targeted to get the patient a better quality of life, not a cure.
Thank you, Professor Saeed.
Statement from what Sean has said yesterday is a chronic disease. And recurrent disease, you reach a situation, not often, where the patient has a good quality of life, but there is an existing disease, and she's had all forms of chemotherapy. The patient is happy, and I quote this word, a chronic disease. Yeah? And in many circumstances, the patient refuses to take more chemo, you can do more surgery, and leave it. Maybe a good option.
Okay, I have a comment from the desktop too, but Professor Rajnaik first.
Yeah. I mean, it's a very good question, and we're seeing that already in our clinics. And I think it's impossible to generalize. I mean, if it shows a 2 centimeter asymptomatic recurrence, do you go in then, or do you go in after 6 months after repeating another CT scan? So I think it's impossible to generalize. I think in some instances, when it's 5 centimeters, clearly involving small bowel, then obviously you'd want to go in earlier rather than later. And I think you have to take into consideration other factors like the age, the morbidities, the potential risk of stoma, and as you mentioned already, quality of life. But then also give the patient the choice. What would she prefer?
Yes, that's right. The desktop 2 trial as well stated that you are likely to achieve complete cytoreduction in the secondary cytoreductive surgery if the patient is asymptomatic. So really, it's a very complex area. Thank you. Less than 5 minutes. We haven't addressed the HIPIC yet, so just need can you progress with the slides number again? Next one. Okay, the one before. Question 18. Okay. Radical cytoreductive surgery and heated intraperitoneal chemotherapy may be the preferred approach in treating recurrent ovarian cancer if settings permit. Okay, a comment, particularly from those who disagree. Okay, Professor Ahmed Mustafa.
Yes, I think hyperthermic intraperitoneal chemotherapy is a form of local treatment, local chemotherapy. So it's an adjunct to the treatment plan to the patient. And if it can be done safely, it wouldn't harm the patient, then it may add to the patient's survival.
Okay, Professor Ahmed Morsi.
I think it's related to the pathology. If you have a mucinous tumor, it can be of help, but I don't think it's of help in serous ovarian cancers.
This
Professor,
is depending on the scoring system.
Okay. Professor Gamal Amira.
Again, the idea will be if you can remove complete removal, if you can achieve R0 in these recurrent cases, the addition of HIPIC will be beneficial. But if you are going to leave a big residue, there is no benefit of the HIPIC.
Yes, no, that's Professor Gamal Hussein and then Professor Mahmoud Milis.
This surgery should be done and the residual disease should be maximum 2 millimeters. If it's more than 2 millimeters, there is no room for HIPIC. Again, HIPIC unfortunately not yet approved in the NCCN guidelines or ISMO guidelines. There is no randomized study published till now comparing the systemic chemotherapy versus HIPIC, but in some cases reported there are some successful cases that the patient can survive up to 50 months after HIPIC.
Professor Mahmoud Milis.
HIPIC, it is used once. It is not a permanent treatment. In recurrent cases, I remove the residual, and then I use not a HIPIC, an intraperitoneal chemotherapy, as we will say today in a lecture, by using a portacas. Inserted intraperitoneal, I can use a chemotherapy repeated doses, reaching to 3 or 6 cycles by using an intraperitoneal portacas, not a HIPIC. It is once to killing the floating cell only during surgery.
Thank you, Professor Wahid, and then Professor Muhammad Hassan.
We have many comparative studies between perioperative chemotherapy, like what you said, and intraperitoneal hyperthermic chemotherapy, with increasing morbidity in the perioperative chemotherapy, and the response rate and the dealing with the patient is more difficult than using a single treatment immediately post-operative in intraperitoneal hyperthermic chemotherapy. So most centers in the world dealing with this issue prefer the intraperitoneal hyperthermic chemotherapy over the perioperative intraperitoneal chemotherapy with the catheter.
Thank you, Professor Muhammad Hassan. Last comment.
To look to the evidence data that we have.